this report covers our general medical services, our out-of-hours services for general medical services, our general dental services, general ophthalmic services, community pharmacy, and also touches upon the work that we do in clusters and the work that our primary and community care academy does. We had a comment made earlier from Llais around GP access, and we are in many ways no different from any other part of Wales or possibly the UK. General practice access being one of our largest services provided. So in 24-25, we had around about 940,000 episodes of care in general medical services. It therefore does generate a significant level of focus, both in terms of good and less good access. And the point was made by Katie earlier that we still have concerns raised about general medical services, and yet when we look at the contractual performance, we have 100% delivery of the access standards. And just highlighting that as an example, because the work that we have to do has to comply with the contractual standards that are national contractual standards that we have to make sure are delivered. I wanted to highlight as well that in terms of our primary care services, the vast majority of this is delivered by what we term as independent contractors. So essentially we commission our primary care services. The exception to that are a couple of our general dental services, which we deliver now through our community dental services. But we review the performance there in the same way that we would an independent contractor. So I wasn't going to go into any of the details any further in terms of this report. I was, however, going to pause and look to my colleague Jane to see if there's any additional headline pieces of information that she wanted to give, and then very happy to open for any questions colleagues may have. Thank you.
Thanks, Elaine. Yeah, the only additional point to make reference in the report is that along with giving that assurance of contract monitoring, it also identifies how that is reported through various executive committees and up to board, which is accumulated in today's slides. Thank you.
Thank you both, and thank you, Elaine, for picking up the observations from Llais. And of course, there was also the affirmation from Llais about the use of Accurex and so on. So whether there's something there that you want to reflect on, then please do. But we will go to contributions initially from Robert, please.
Thank you. Very interesting report. First of all, the patient survey data, has this appeared before PECS? Yes, it goes to PECS. Yes, okay, thank you.
Nodding heads, Robert, yes.
Oh, right, that's...
Yeah, nodding heads.
Good.
Sorry,
yeah, okay.
Yes.
Yeah.
For the reasons you've mentioned, Elaine, in view of the importance of access and the feedback obtained not just from Llais, but in numerous national reports, I would invite the board to accelerate the goal in the delivery plan, which is, you'll know what this is, Elaine, enhanced primary care bullet point 3. At the moment, it's Q3 to Q4. My concern about that is because there will be subsequent actions, as mentioned on that line, that will then push it into the next year. So I'd be grateful if that could be looked at to bring it back a little earlier. And then two quick questions. The first is electronic prescribing. It mentions significant opportunities. Last time I heard there was an obstacle to the adoption of the 56-day prescribing. I just wondered for an update on that. And then the back to GPs, you mentioned in the report, one of the risks is the longer waiting times impacting on GP work. And bearing in mind that we are about to make further changes, particularly on NHSE, which could have then consequences for additional loads for GPs. I wondered when we'd be in a position really to assess the degree of that additional load and how it can be mitigated and maybe even paid for. I don't know. Thank you.
Thank you, Robert. So if I pick up those three questions, and happy for colleagues to make any comments, or Jane to add anything that I've missed. In terms of the access timeline, that's quite a purposeful timeline, because a holistic report also depends on a national data feed that we would get, and we don't tend to get that data feed until Q2, Q3. So until we've got that, being able to respond to that wider access ask can be challenging. So we can have a look at that, but I think we are dependent on the national data feed that comes through to us around the annual review and the patient feedback that we get for general medical services. In terms of 56-day prescribing, I think one of the challenges that we have in Powys with 56-day prescribing is we have a significant proportion of our GP practices which are dispensing practices. So a large number of our rural population pick up their prescription from their GP practice rather than from their community pharmacies. So what we have seen is where we have a higher level of prescriptions issued through community pharmacies, we have a higher proportion of 56-day prescribing, but some of the contractual terms around how contractors are paid for prescribing and dispensing medication make it less favourable for dispensing practices to deliver that 56-day prescribing. So that has been a challenge that we've faced, and it's a challenge and a conversation that we have with colleagues in Welsh Government on quite a reasonable basis to make them aware of that for us in Powys. The final point that you've raised about longer waiting times and the issue and workload impact on general practice around that. We've had conversations with our general practice colleagues, particularly when we were looking at our commissioning plans for last year. It is an issue that has been raised and a concern that has been raised, particularly in certain parts of Powys. And I think we recognise that there's a very variable impact on that depending on where the GP practice is located and where we might then refer into for secondary care activity. We haven't got any information at this point in terms of what does that additional waiting time mean in terms of demand and expectations around general practice activity. But I suggest that we take that away and we can have a conversation, maybe a conversation with our cluster leads as well, to see if there's a way of identifying and articulating that.
You okay,
Jane,
Robert?
I didn't. Oh,
sorry, Elaine. Sorry, Jane. Did you want to come in?
Thank you, Chair.
No, nothing further to add. Thanks, Elaine.
Okay, thank you. So Simon.
Thank you, Chair. Just to confirm, we have had, as we noted earlier, the patient experience report to the PECS committee at its last meeting, and it's just on that I was reflecting a little and just wanted to sort of ask. A lot of this is around contracts, reporting around the specifics of the contract management, and do we have sufficient attention given to patient experience? Are there more things we can do to get a better handle of patient experience across primary care? What actions might they be, and when might we be looking to take them? Thank you.
I might ask Jane, who'll be closer to the detail on that, to come in.
Yes, thanks, Simon. So you will you referenced the report that went to PECS in, I think it was February of this year. That one of the new initiatives that we've done to sort of really get into the patient experience is receiving the raw data of the patient experience survey, that are undertaken in general practice. And at time of writing the report, I think we had approximately 5,000 patient views that we accumulated into analysis that was presented in that report. We've had further contract deadlines are the 31st of March. We've had further patient experience surveys in. So our next iteration of that report going to PECS will have the full sort of picture of patient experience surveys that have been undertaken in the last 6 months within general practice. We're the only health board in Wales at the moment that has agreed with general practices to get access to that raw data so that we can do that more detailed analysis to provide assurance to board committees.
Thank you, Jane.
You and Rhiannon, please.
Thanks, Elaine. The echo Simon's point about patient experience. So good to hear you're getting a reasonable volume, and I'm sure more work to do. I also just wanted to comment positively on the Primary Care Academy. Kate was telling me about it last week, and it sounds really brilliant, actually. The investment in staff, and good to see the GP nurses getting something valuable out of that. My question was around community by design. I just wondered if you could just offer a little bit in terms of obviously recognising it's a national programme, just what that means for us in Powys, where we're starting, etc., etc. Thank you.
Thank you, Rhiannon. So just for context, Community by Design as a national programme is in its early stages. There are 3 main work programmes. One is around prevention and population health, one around urgent and same-day care, and one around chronic conditions and multiple chronic conditions for the population. We're engaged as a health board with the national programme and sitting as part of the programme board for that. And we are expecting within the next couple of months there to be some more specific and more detailed pieces of work around how we can develop and consistently develop across Wales our responses for the population around those 3 key pillar areas. The key focus being on increasing and improving the services that our population receive from primary and community-based services. I think it's important as context just to add that we know in Wales, if we look just at general medical services, that we've got a larger proportion of what are called supplementary services, so additional services that we commission through our independent contractors to be delivered to ensure that we are building and strengthening care closer to home for our population. So we know we've got a really strong position there. I think that as across Wales, we focus on that further. There's a question for us around which of those do we need to develop, which of those need to be aligned to the national directed supplementary services, and which of those can we change or evolve because they will support us in terms of what we want to deliver locally within Powys for a population, and strengthening the work that we do through our collaboratives and through our clusters.
Yeah, thank you, Elaine.
Thank you. So I think that's all the questions or contributions that that we have. Oh, sorry. No, yes, it is. Therefore, thank you, Elaine and Jane, and we move to the recommendation associated with this report, and that's that we take assurance that robust governance and monitoring processes are in place across the primary care portfolio, including relevant reporting to both Executive Committee and other relevant board committees. Once again, I'll pause should anyone want to comment on or dissent from the recommendation. That, therefore, is also supported unanimously. Thank you. So that brings us to item 3.5 on our agenda and to the organisational escalation report. We have mentioned a couple of times in our meeting today that we continue to be in level 4 escalation within the NHS Wales escalation framework, and that's for finance, strategy and planning. As a board, we retain direct oversight with the support of all our committees on this position, and importantly, we seek assurance on relevant areas of the de-escalation journey and the de-escalation criteria. So twice a year, as a board, we receive a direct report from our Chief Executive. And on that note, I'll hand over to Hayley. Thank you.
Thank you, Chair. So yes, this update today in the papers covers the work that we've been undertaking over the last 6 months. As the Chair's mentioned, our level 4 escalation is in regard to finance strategy and planning, and that's where Welsh Government take a closer interest in how we are managing those. But we do remain in routine monitoring for all of the domains of the escalation framework. Clearly, the update report, I won't go through the detail, but it continues to focus on the work that we're doing to demonstrate grip and control, how we're overseeing key areas of risk and important areas of work against our de-escalation criteria. We know that we need to continue to improve our financial position, and we've just considered our annual plan and the route map conversation that we've just had previously that will be submitted to Welsh Government. Part of that is also around our capacity and consistency to deliver, and the way in which we are working closely with Welsh Government to ensure full transparency and support around the actions that we're taking, in particular in response to the independent review commissioned by Grant Thornton, and how those recommendations have been accepted. Majority of the 34 recommendations have been accepted. The only ones where we haven't accepted fully is where those actions would require action to be taken on a broader footprint than just our health board, broadly speaking around some of the commissioning arrangements which are in the shared space across NHS Wales, and also around the way data is collected. So our focus remains on continuing to focus on how we can de-escalate further as quickly as we can, and the actions that we're taking to address the remaining challenges. So you'll see from the update that sets out how we're monitoring progress and ensuring a clear line of sight from how we're planning delivery through to board, and how we're expecting monitoring and escalation against our annual plan and our financial recovery trajectory to be monitored through the relevant committee and boards. I also referenced in the first report, my Chief Executive report, around the revised governance and oversight arrangements that are put in place by Welsh Government from the 1st of April. And again, we will continue to monitor and bring an update on the progress on that to the public board, so that we can be open about both the improvements we're making, but also the remaining challenges that we've got to achieve in order to address the full de-escalation criteria that's set for us. So I wasn't going to say much more in introduction, but I'm happy to take any questions. Thank you.
Thank you very much, Hayley. Colleagues, does anybody want to contribute to participate in discussion in response to our escalation assurance report? No. So as Hayley says, this is here as a source of assurance that we have the necessary arrangements in place to monitor our response and our journey in relation to our de-escalation criteria. So if there are no further comments, then the recommendation is that we receive the report and that we take assurance that appropriate mechanisms are in place to monitor and report to the board and its committees against the level 4 de-escalation criteria. I'll pause again for the same reason as I've paused in relation to previous agenda items. Nobody is indicating that they don't support the recommendation. Therefore, that too is supported unanimously. Thank you very much indeed. I think we've all deserved a lunch break, and therefore we will take 30 minutes for our lunch break, and I ask that we reconvene at 1:30, please. So bon appétit. See you at 1:30. Croeso nôl, pob un, ar ôl ein hegwyl ginio. Hyfryd i'ch weld chi unwaith eto. Felly, dyn ni'n ailgydio yn ein hagenda wrth ffocysu ar item 3.6. Very warm welcome back after our lunch break. We reconvene and we look at item 3.6 on our agenda, which is our financial performance report for month 11. And Pete, please do introduce this.
Yeah, thank you, Carl. Excuse me. So we picked up on a lot of the financial position in our early discussion around the plan. Included in the papers is the finance report for month 11. Clearly, as we're on the 25th of March, we're very near to the financial year end. So if I go through and give a couple of key highlights, and then we can use the time for any questions and further discussion. So as of month 11, we do remain on track to deliver our forecast deficit of 33.3 million and on track to deliver our capital position within the capital resource limit of 8.392 million. At month 11, our actual revenue overspend is 30.214 million. And as has been the main areas of our cost drive or areas of pressure, they continue to be those commission services, our use of private providers for mental health and LD, pressure against pay, and continuing high levels of spend in relation to CHC, although noting that is within the plan that we set at the beginning of this year. I think it's worth referencing our spend on agency. It's included in the report on one of the tabs. You will see that our spend in this area has remained static in month 10 and 11. Pleasing to note the overall reduction. We're meeting the target of a 30% reduction in spend in this area for the financial year, but also noting this will be an ongoing area of focus. We've got requirement to reduce by a further 30% in the next financial year, and clearly all of the operational and patient care benefits that go with that reduction in spend. I also wanted just to highlight the savings performance. You will see on the relevant table, it's included on page 10 of the finance report, that we are forecasting to deliver £20.385 million worth of savings. That is a huge achievement for the health board and for Powys, and probably the highest level we've ever delivered, noting that our target for the next financial year is slightly above this level. It is worth pointing out that in that delivery against the 20.385 million, 9.3 million has been delivered on a recurrent basis, and that difference between recurrent and non-recurrent deliverability leads into the difference between our forecast outturn and our underlying deficit, which I highlighted earlier. Similar analysis is included in the reports in relation to our spend on commissioning, prescribing, our use of private providers, and continuing healthcare. Rather than go through any further details in those areas, I will pause there, Carl, and happy to take any questions or further conversation around it. Thank you.
Thank you, Pete, and as always, thank you for a very accessible and easy to navigate report. Much appreciated. And I know at the risk of repetition, just to support your comment, Pete, about the impressive performance against our £20.385 million savings, and you know, from a board perspective, I just want to express recognition and appreciation to everybody across the organisation that has contributed to that. But colleagues, please do indicate if you'd like to enter into the discussion on this report, and initially we'll go to Steve, please.
Yeah, thank you, Pete. Really helpful report as always. Conscious that we're obviously just 1 month away reporting from the year end, so good to hear the assurance that we're expected to meet our revised deficit. Just a couple of questions really. Firstly, in terms of the secondary care delays, the schedule that's provided on a monthly basis, I raised this last time. There's been quite a significant shift between the number of health delays and the number of social care delays. I think health delays, if you compare with the same position last year, has increased by over 4,000, and social care delays have dropped by around 6,000. There's a reference there to a change relating to the reablement service. So I just wondered if you're able to give any assessment of the scale of that impact and whether that's driving the shift that I've just referred to. And then I know you've said that we're expected to achieve our capital resource outturn, but that means that we're going to have to shift 45% of our total capital budget in the last month. So just a sort of further assurance really about the actions being taken to achieve that. Thank you very much.
Yeah, thanks, Steve. I'll maybe ask Elaine to come in relation to the delays in relation to capital. That report position month 11 is reflective of what we've actually paid out. There's a high level of work in progress positions which will be subject to payments in these last number of weeks. So there's been a significant amount paid since 1st of March, and regular assurance has been given by the capital team, including the finance support for that capital team in terms of the position and the management of that towards the year end. So not in a position where there's any need to escalate anything to the board. And on the first question, sorry, if Elaine's okay to come in, thank you.
Yeah, thank you, Steve, for the question. It's a question you raised last time as well. So we undertook a change in terms of configuration of the teams of our enablement service. What that led to are delays that in the previous year would have been allocated to social care. A significant number of those have been allocated to health this year because of that change in that service. That equates to the vast majority of that significant shift. What I would say is if we look at month 11 last year and we look at month 11 this year, we've seen a significant downturn or improvement rather in terms of the cost of those delays. So month 11 last year was 17.6 million, month 11 this year 14.9 million. So the total is improving. There's been that change because of the operational configuration. It's a significant area we're continuing to work on in terms of building our community capacity going forward.
Thank you.
Thanks, Elaine.
That's helpful. Thanks.
Thank you. Okay, so we go now to Jen, please.
Thank you. Pete, probably not one for you, but one for your colleagues. It's about the prescribing section you've got in your report. It's really, really good to see and note the continuing trend in terms of reducing our prescribing costs, our medicine management savings, etc. And I know that many of us have seen the detail of that in the subcommittees that we sit on. I note in risk and challenges that one of the risks are it's identified as responsibilities for prescribing versus accountability for the prescribing budget. And I just wondered if somebody could talk a little bit more about why that is a challenge. What is it about our structure that is causing that is potentially a risk and a challenge to us? Thank you.
Thank you, Jen. I think in simple terms, it's where the prescribing of those drugs and where the costs of those drugs sit are in different places. So we hold the spend and the budget, but it's obviously prescribed within primary care in the majority of cases.
And the work that we're doing to keep managing that, to make sure that that we are sort of monitoring that activity, that there are robust places in processes in place to do that.
Yeah, it's an area of close attention. There's numerous dashboards used to report against this. I'm sure Kate would like to come in, and I will say it's an area of success in terms of the approach of the medicines management team and the financial management side of it, whereby they've identified schemes to deliver 2.5 million savings against their original target of 1.5. So there's a lot of positive work in there and a lot of detailed, good reporting needed to deliver that. But I will let Kate come in with any further comments. Sorry.
Yeah, thank you, Pete, and thanks for the question, Jen. So absolutely, I think Pete summarised, but there is very close working relationship with our primary care colleagues. Emlyn, our senior pharmacist for primary care, head of primary care pharmacy, has a lot of data, dashboards, graphs, which she shares openly with the practices. So the shared learning, feedback, which is well received from the practices, and we are on the whole seeing downward trend and improved prescribing in many areas. So it's a continual process, but actually there is very, very close working. And as Pete says, delivering significant savings.
Yeah, thank you.
Chris, please.
Yeah, thanks for the report, Peter. I think it was really helpful, and again, echo the sentiments that Carl said about all of the efforts that have gone in to make the savings that we've achieved. It's quite a feat, really. I'm referring to page 5 of your paper, and there is vacancies of 19% on there in relation to mental health and learning disabilities. Are we, I mean, that comes in two things. One, it would assist with the budget in some ways because of those vacancies, but obviously adds some risks in there. How is that being managed?
So thanks, Chris. Yeah, as you'll be aware, there's a very detailed approach to recruitment and retention within the health board, regularly reported via committees. So those vacancies are a result of turnover and other factors. It's not that anything's being held back, and clearly there's a focus on getting to full establishment in those clinical areas to deliver the care that we require, and that obviously has a positive impact in terms of our agency spend.
Yeah.
Thanks,
Okay.
Pete. I wonder, in response to that, Chris, whether the Executive Director for People and Culture, Deb, would like just to offer a comment.
Yeah.
Thanks. Thanks for the question, Chris. We monitor vacancies and we're fully aware of the position in mental health. My team are now doing a targeted piece of work to fill both clinical and non-clinical work. It will be helped by our aspiring nurses that are qualifying this year, some of whom will go into mental health. And obviously we've had our approaches with overseas doctors. We do have a targeted piece of work around healthcare support workers, and that's an extension really of the work that we did last year, which saw the reduction in the 30% agency spend that Peter's referred to. Clearly there is more to be done in mental health to help us get towards the 30% that we need to deliver this year.
Okay, thank you.
Thanks, Deb. I'll just pause slightly. Should anyone else want to ask a question or contribute in response to the financial report? No? So thank you, Pete. Therefore, we are asked to receive the financial report and to take assurance that the organisation has effective financial monitoring and reporting mechanisms in place. We are also asked to consider and discuss the financial forecast for 25-26, which is £33.3 million, and also our underlying deficit of £45.1 million. Once again, colleagues, please indicate if you have any further comment about that recommendation, or if you would like not to support the recommendation. That therefore is supported unanimously. We turn to item 3.7 and to the integrated quality and performance report as of month 10. And just before I invite Nick to come in and talk to this report, as with other reports, this has been to the exec committee and also went to our F&P committee as we reported earlier. I also draw attention to the comments from Llais at the beginning of our meeting in relation to this report, and perhaps you could pick those up, please, if you would, Nick, in your introduction. Thank you.
Thank you, Chair. So I'll pick out the main points to note from the report that have changed since the last report that the board received. A noting this is performance up to month 10, which is January 2026. In terms of the provider, Powys as a provider, we continue to meet the 52-week and 104-week waiting times target, and to perform well in our MIUs on the 4-hour waiting times target. And obviously that plays into the previous paper we've had on temporary service changes. There is a deterioration in this report in terms of our diagnostic waiting times performance, with issues around sickness in small teams. However, we are ahead of the trajectory that we set for ourselves to achieve that target by the end of March. Therapies rates have improved, and thank you to those teams. Again, small teams across the county, but thank you to those teams in terms of delivering that improvement. With regard to mental health, there's largely compliance with the mental health measures for under 18s, with a very slight drop in compliance with care and treatment plans being agreed for children and young people, which just took us very slightly underneath the target, but that is unusual in this service and we expect that to recover. And in adult mental health, good sustainable improvement across 3 out of 4 of the measures, with a gradual improvement in the measure around care and treatment planning. I'm really pleased in this report to report to the board that there are no children exceeding the 104-week wait for an assessment for a neurodevelopmental assessment, which was the ambition that the board set for itself, but is also the improvement target set for the Health Board by the Cabinet Secretary by the end of March. And we talked about our further plans for that service when we talked about the annual plan item earlier. We have picked up a reporting issue with national reported incidents and the comparison back to the national data, and that means that's not included in this report, but will be included in reports from month 12 onwards. In terms of commission services, the pattern of service delivery very similar to the last report. So we're seeing that ongoing improvement in NHS Wales waiting times to meet the 104-week standard, as expected, with that central monies being deployed to health boards, and we'd expect to see that further up until the end of March. In NHS Wales, that particular issue in Robert Jones and Agnes Hunt Hospital is evident in the data. So a problem with the cohort of long waiting spinal patients and a difficulty of the Trust's capacity to treat those. And again, for those very complex spinal patients, that is a national issue. However, the provider is exceeding we agreed a cohort of 63 long waiting patients with them, and they are currently exceeding that. And we are meeting with them fortnightly to assess that. And they are projecting to exceed that by the end of the year. We have done with them, in collaboration with them, a trial clinic for patients on the waiting list at earlier stages, which has been very successful, and we are now working with them in the context of 26-27 on our plans to address those very long waiting patients, whilst also working within our commission intentions to book to NHS Wales waiting times. In Wide Valley, you can see the effects of our commission intentions with waits continuing to lengthen, but nowhere near the 104 weeks yet. And we talked about Shrewsbury and Telford hospitals earlier under the annual plan item. The cancer pathways, that varied performance that we see across all providers still exists. and with emergency care, as raised by Llais, that concern around ambulance performance times. I did address the issue around patients choosing or being told to self-convey to hospital under the annual plan items, so not thinking of repeating that here, Chair. I know the other issue was around test results. Obviously, for some very specialist tests, I've discussed the issues around diagnostics. And I believe Kate, as medical director, has supplied further information to Llais on other issues with regard to that. And in access times, note the comment that Katie meant in terms of that only measures one part of how the system is performing. However, those are we report to the board on the measures that are agreed on a national basis. So that's it for me in terms of introducing the report. Thank you, Chair.
Thank you, Nick. So we have a couple of colleagues wanting to discuss the report, and we will go firstly to Robert.
Thank you, Nick, for the report. Yes, we've seen this report already, I think, so I'm not going to comment on the details. I just wanted to pick up two other things. The first is, as far as commission services for next year, the individual health boards will be working up their own plans, and I just wondered, will they then indicate on an individual basis to you whether or not they think that waiting times, for example, will improve, or will they not improve based on their own financial circumstances? And the second thing is about WAST. I think we have discussed in the past about perhaps a more suitable measure for WAST in Powys would be not simply the time it takes for the ambulance to arrive, but the time from the call to the door of the hospital. And it turns out, I've only recently found this out today actually, that WAST are making that measurement for stroke patients, so I assume it could be done for all patients, and I think that'd be a useful indicator for us with the issues that we have. I sent you the report anyway for you to see, but be grateful if that could be examined as whether or not that could form part of our reports next time. Thank you, Chair.
Nicola?
Thank you. With regards to other health boards' performance, all health boards have indicated to us, even in conversations around their plans or directly with regards to their LTAs, that they are expecting the planned care waiting times that they will be struggling to meet those from the 1st of April onwards. Not necessarily because of choices they're directly making, but because the improving performance this year has been heavily reliant on central monies, which it's really clear in the planning framework not going to be available next year. So cause for concern there in terms of our patients on waiting lists in other parts of Wales. With regard to the measures for WAST, those are centrally agreed through JCC, but your point is well made, Robert. That does exist in terms of stroke patients. We will take that back to JCC and WAST and see if that can be put in place, but I wouldn't want to commit to that being in the next report without having that conversation first. Thank you.
Thank you. So let's go to Rhiannon.
Oh, thank you. Thanks, Nicola. Just obviously, the report isn't necessarily familiar to me, so unlike other colleagues, just bear with me if I'm asking things that others are aware of. So there were a couple of points on the diagnostic pathways referenced in Table 1. It refers to in-reach or extra capacity in terms of in-reach providers. I just wondered what our confidence was in terms of sourcing that in-reach provision, because it's talking about the year end, and obviously we're very near that. So that was one of my questions. The other one, I won't ask about the neurodevelopmental performance, because I think that has been discussed. But in relation to children and young people CAMS, in particular North Powys, and there's a reference there to a recruitment will improve the performance by year end. I suppose I was just reflecting on whether the models of care going forward, there'll be further resilience built in, because it does feel quite single point, and I wondered if there's work in terms of I suppose adapting the model of care for greater resilience. And my only other is more of a comment, really. I suppose looking at table, I'm trying to think what table it was. It was the table in relation to giving the dashboard a RAG rating, but it actually doesn't present it in a RAG way, in a color coded way. I think it's quite hard to read the narrative in that sort of black and white format. And I just wondered if there is an opportunity. It's on page 9 of 13 or page 361 of 706, where there's opportunity just to look at how that might be presented, pulling out that kind of RAG status a bit more clearly. Thank you.
Thanks, Rhiannon. So Nick, and I think Elaine might want to contribute as well in terms of the diagnostic inReach, but back to you, please.
Yeah, take on board that comment about the RAG rating. That's quite a lengthy table. So it was about the conciseness of this report, but we can append it to the report going forward. And it has been included in the annual plan packs to board development, Rhiannon. But yeah, thank you for that comment. Appreciate that. On the detail of the service issues, I'll pass to Elaine. Thank you.
Thank you for the questions, Rhiannon. So in terms of diagnostics and our performance, notwithstanding the risk that we have within the next week a clinic cancel because somebody isn't available, we are expecting to hit that 0 breaches at year end, and we're confident of that, notwithstanding that one mitigating factor. And in terms of children and young people, mental health and learning disability, part of our challenge is the small and broadly spread teams. We have performed really well in terms of our mental health LD, mental health measure performance this year. This is the first time we've dipped below that target of 90%, really small drip, and related to the combination of one vacant post and some sickness that came. So we don't anticipate that will be an ongoing problem. Remains always a challenge for us that we're managing small teams, but we monitor that really closely. Thank you.
Appreciate that reassurance. Thank you.
And Jen, would you like to contribute, please?
Yes, thank you. I just want to pick up on page 3 about the ophthalmology paragraph there. Not so much about the detail. We note that the performance has fallen. Not so much about that, but the why. And the why being that as a result of the, as you say here, the inReach fragility of Wye Valley Trust into Mid-Powys. And then it says with significant underperformance against contracted inReach sessions. And I just wondered, the principle of that, it begs questions to me. Do we have opportunities? Compensation is not the right word, but how are we able to challenge Wye Valley Trust if they are underperforming? Is there some sort of financial recompense, or how do we manage that? I'm sure the figures are very small, but the principle of holding them to account for their contract, I'd be interested to know how we do that. Thank you.
Thank you, Jen. To reassure the board that we only pay for the activity and the sessions that are actually provided by the trust. So we don't pay for sessions or activity that isn't supplied. However, there is particular fragility in that service. The operational team are working really closely with both the consultants themselves and through the commissioning team with the trust. However, in terms of the sort of more transformational activities in planned care that we described under the annual plan and the Getting It Right First Time team report that we're expecting in April, it will be something that we'll be looking at to assess all the options to modernise how we secure clinical input into our own provider services. I think that the historical SLA type arrangement on a consultant by consultant basis is something that we're going to have to look at very carefully, and we may want to do something quite different in the future.
Thank you. So that concludes the contributions from board colleagues, in which case it takes us to the recommendation, and that's that we discuss the content of the report that has been done, and that we take assurance that the Health Board has appropriate systems in place to monitor performance and respond to relevant issues. I'll pause again should anyone want to comment on the recommendation or indicate they don't support the recommendation. That also is supported unanimously. Thank you. We turn our attention now to item 3.8, to the Strategic Risk Register and Board Assurance Dashboard, and our Director of Corporate Governance, Helen, will introduce this item to us. Thank you, Helen.
Thank you very much, Carl. I'm pleased to present the package of papers that you have in front of you today on behalf of the executive team, and where needed, I'll bring in executive colleagues who are the senior risk owners for each of the relevant risks. So just to briefly summarise what you have in front of you then, the Strategic Risk Register, that's at Appendix A. Just to remind us, these are the 12 board-approved strategic risks. 2 of those are considered in committee, which we'll do a little bit later on stage due to the confidential nature of them. But you can, on the dashboard, see the overall summary of the scores and risk appetite position. We continue to consider all of these strategic risks within the relevant committee and to seek assurance on behalf of the board that those are being managed appropriately. Appendix B then is the board assurance framework. This continues to be new to us as a board within the last 12 months. This is focused on the assessment of the strategic risks in the context of the controls and the assurance levels that can be offered to the board as a result of the actions that are being taken. It also identifies where risks are operating within the board appetite and indeed where they're not. And as you'll see from the report, we continue to have 3 that are not operating within appetite. That's risk 1 on financial balance, risk 7 related to our estates, and risk 10 related to incident response, and emergency response. And as we have discussed throughout the agenda today, we've covered some of those topics, certainly in relation to estates and financial balance when we considered items earlier on. And then twice a year, we also bring you a summary of the organisational risk register. That's Appendix C. These are the risks that operate at executive level. They are essentially beyond the control and influence of a single director or directorate, and therefore span certainly a part of the organisation. This component of our risk management framework is new in 2025-26. We will continue to develop that, as you can see. You'll also see that there is more likely to be a greater level of change in both scoring and escalation and de-escalation within this area. So you'll see in the report that Executive Committee have de-escalated 1 risk in the last month, but also identified additional risk to be added, including a risk around dental services. So in summary, then, this is essentially the bringing to life, the implementing of our risk and board assurance frameworks. The annual review of both of those frameworks will come back to the board in May. We continue to develop. We've heard earlier on today about some of the recommendations also made in our structured assessment from Audit Wales as well. As you'll know, the board has already commenced its annual review of its risk appetite, and now the board has considered and accepted the annual plan earlier on today. We will also now undertake our executive review of those strategic risks and report that back to the board in May also. So very happy to take any questions or comments, Carl. Thank you.
I can see that Steve wants to come in, so please do, Steve.
Yeah, thank you, Helen, and good to see the work. Very comprehensive piece of work ongoing. Can I just ask? I note that in terms of the strategic risks, there's been a lot of updates of the mitigating actions, controls, etc., and yet none of the scores have changed. And I just it begs the question, really, are the controls acting effectively? You know, are the mitigating actions acting effectively? So I'm just interested why, you know, you'd expect to sort of see some change in scoring, I would have thought, with the update, and we haven't seen any of that. So just really interested in your take on that. Thanks very much.
Yeah, thank you, Steve. Thanks very much for the question. I guess it's a bit of a challenge in the respect of the point you're making, because the strategic risks are so strategic. There's a reality to how often and how much those things will change. I agree with you, though. There is something to consider around the effectiveness of our controls and assurances and whether or not they are making impact over time. I think we probably need to undertake that assessment on a timeline basis as opposed to within an individual review. So I think that's part of what our board assurance framework should be helping us with as we move forwards, and we'll make sure that that's included moving forwards. One of the things that we will do in the annual review is just check, benchmark ourselves. Have we got the right risks at strategic level, and have we got the right risks at organisational level? I think there is a little bit of levelling out that we may need to do there, and that I think will in part answer some of your question as we move forwards. But I think it's a very very appropriate and a clear point that we do need to pay a bit more attention to.
You can, Steve.
Yeah, thank you. And probably also just to recall that there were some recommendations from Audit Wales in the structured assessment around the management of risk as well. So I look forward to picking that up next time. Thank you.
Thank you. Robert, please come in.
Yeah, 2 points, if I may, really. First of all, yeah, structured assessment. In the past, this has been mentioned. So actually, you've made huge strides on our behalf, Helen, and it's good to see it all together. And as well as looking at the risks themselves, in one committee that I'm a member of, we've started to look at the evidence we need to be able to quantify those risks as well. So it's sort of had the this wasn't something we thought would happen, but it has happened. We've started to think about the evidence we need as well. So thank you for stimulating this discussion on something which, you know, perhaps in the past we might have viewed as simply sort of dry material, but we are working on, you know, the evidence that we're going to need in order to be able to consider the risks. Thank you very much for your work anyway.
Thank you. And Rhiannon.
Yeah, thank you, Carl. Thanks, Helen. More comments and questions, really. I would echo your reflection on revisiting them and I suppose challenging ourselves in terms of, are they captured at the right level? I think also your point about having a sort of trajectory of when we might expect to see what by when would be really helpful. Not necessarily easy to do, but I think helps us to understand the journey and when we think we might get there. And I think the other point then comes back to the structured assessment. I have to say I disagree with Audit Wales' view on not having strategic risks aligned to committees. I think it's actually really important as part of the governance that they are. So hopefully we can find our way of reflecting that back. I don't think I'm alone in that thought. So just a point there to consider. Thanks.
Thank you, Rhiannon, and thanks, Robert, for your comments as well. Rhiannon, I think you're right. I don't think it's either or. I think it's both, and I think it's how we reflect the strategic and organisational risks at the right kind of level in the right governance forum. So I think that's absolutely right. Carl, if I may, just to say that, you know, risk management is a huge collective effort. So big thank you to my executive colleagues, but also our other colleagues that support the kind of implementation of the whole framework throughout the organisation. What we see here is our kind of strategic and operational level. There's a huge amount of other work that kind of goes on. And just perhaps a reflection, I think over the last 12 to 18 months, we've seen quite a significant shift in the way in which we talk about risk and how we integrate it, not only in reports such as this, but, you know, as we're talking about other items, it's becoming more and more embedded and included. So just to thank colleagues for that, both independent members and executive colleagues. I think that's a significant shift in our maturity in risk. So thank you.
Thanks, Helen. Just before we leave the item, I just wondered, Helen, whether you or would it be Mez or somebody might just want to offer a comment. You mentioned earlier that we have 3 of our 12 risks that are outside of our risk appetite. As you indicated earlier, financial balance and estate, I think we've discussed that and we've explored that and exposed that, as it were, within our meeting so far. In terms of emergency preparedness and incident response, we can see in the information that the journey is a good one. You know, the risk is being lowered and minimised, but nonetheless, it's still outside of our appetite for that particular risk. So I just wondered whether a comment or two on the confidence we have of being able to get within appetite or not.
Yeah, thanks, Carl. Mez, would you like to comment on that? I think a lot of this sits within our cross-organisational emergency response points, doesn't it, and plans?
Yeah, thank you. Yeah, thank you, Chair. So in terms of background for this one, I think it was just earlier on this year or end of last year, we did start to reduce it down in reflecting the plans that we have in place, but recognising we have got a target of 6 as well. So it is in relation, as Helen said, to preparedness, but also response. And you'll recall sort of last year we were involved in the pandemic exercising element, and we are waiting for some of those national plans to be published in order to update our working plan. So it's a continuous sort of working progress, working not just as a health board, but also as an LRF region, but also within government as well. And then just to sort of mention, since we updated this plan, obviously with the Middle East conflict, etc., that's another element that plays into us in the health board in terms of our planning arrangements. So it's something that we continuously review.
Thanks, Mez. That's really helpful. It's just sort of helpful to get a sense of the controls and so on in relation to that. So a big thank you, Helen. I can't see that anyone else wants to come in. So we will go to the recommendation. That's that we receive your report. But also, as indicated in the report, the board ratifies 2 chairs' actions taken since the last meeting of the board held on the 28th of January, and also that we note the update provided in relation to the health board's petitions protocol.
Carl, with apologies, I think that's just the next set of
recommendations. Oh, sorry, yeah. No. Thank you, Helen. My eyes had skipped over a bit. You're as I read it, I thought this doesn't sound quite right. Forgive me. Let's reset. The recommendation on this against this agenda item is that we review the March 26 Strategic Risk Register update included at Appendix A, ensuring that it's a complete and true reflection of the Health Board's current high-level risks. We review the March 26 BAF dashboard update included at Appendix B, ensuring that it's a complete and true assessment of the Health Board's confidence in its strategic controls and assurance. We take assurance on the development of an organisational risk register encompassing the most significant operational risks the organisation, a high-level summary of which is included in Appendix C. And finally, we take assurance on the controls and assurances to manage strategic risks, and there are actions to address any identified gaps. Once again, does anyone want to comment on or dissent from supporting that recommendation? That therefore also is supported unanimously. So apologies again for my brain slightly slipping out of gear, but we'll get back on track. Item 3.9 of our agenda. We're staying with Helen for the Director of Corporate Governance report. Thank you, Helen.
Thanks very much, Carl. So a much shorter report from me this time, which I think is quite clear and straightforward, I hope. So just to quickly summarise, it gives you an update of the board's key activities since our last meeting in June. We continue to make sure that this is publicly reported in terms of our transparency standards. It also gives you an update on the 2 chairs' actions that have been taken. The first one in relation to dental services in Llandrindod, and the second one with regards to the procurement and contracting arrangements for our electronic healthcare record system. And then just lastly, it provides an update for you on the Healthcare Professionals Forum, which I'm very pleased to say we had the first meeting of last Friday, as you noted in your report earlier, Carl. And then lastly, an update on the Health Board's petitions protocol. Thank you.
Thank you, Helen. Colleagues, does anyone want to ask a question or make a comment in response to the Director of Corporate Governance report? No. So we come now to the recommendation of that report, which is to receive the report, to ratify the 2 chairs' actions, and to note the update provided as regards the Health Board's petitions protocol. Once again, do come in if you want to comment on or not support the recommendation. That also is supported unanimously. Many thanks, Helen. Item 3.10, we consider the minutes of the previous meeting held on the 28th of January 2026. For accuracy, are there any changes, amendments, corrections to those minutes that anyone would like to suggest? They therefore are accepted as a correct record. And we then turn our attention to section 4 of our agenda, which is the consent agenda section. I've mentioned this a couple of times in our meeting so far. We don't discuss any of these items, and therefore we support them en bloc, and that we do. I'm not aware of any other urgent business that requires our attention today, and so that in effect closes the business for today, or concludes the business for today, and it simply remains, as always, for me to say a very, very big and heartfelt thank you. We've had some pretty whopping items on our agenda today, and a huge amount of work and preparation has gone into the preparation of these reports, and of course the work that will ensue from them in terms of the implementation of plans and so on. But I simply want to assure everyone that that work is noted and much, much appreciated. And can I also say a thank you to Helen and the team for the support they give to the board in carrying out its work, and the preparation that goes into to supporting and to making these meetings flow so smoothly. That support is second to none in my view, and so again, noted and much appreciated. So that closes our meeting for today. Our next meeting is scheduled for the 20th of May 2026. But we do have an in-committee meeting that will meet very soon, in fact, within a few minutes of closing this meeting, and therefore I need to put to you as a board a motion that enables us to meet in committee. So with advice from Helen, our Director of Corporate Governance, I've determined that the following items include confidential or commercially sensitive information which isn't in the public interest to discuss in an open meeting at this time. As a board, you are asked to take this advice into account when considering the following motion to exclude the public from this part of our meeting. And this motion is taken from section 1.2 of the Public Bodies Admission to Meetings Act 1960. The motion is that representatives of the press and other members of the public shall be excluded from the remainder of this meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest. As is our wont, would you please indicate if you don't approve of and support that motion? It is therefore supported, and therefore we will meet in committee. And colleagues, can I ask that we start our in committee meeting at 2:30, please? Thank you.